Okay, good afternoon, ladies and gentlemen, dear patients and relatives. My name is Felix Ringshausen from Germany, from Hanover Medical School, and it's a pleasure to introduce you to session number 3, the latest research in bronchiectasis. And as I've done a couple of times before, it's my amazing pleasure to introduce the next speaker. It's Professor Stefano Aliberti from Milan in Italy, and he is going to tell you something about why you have bronchiectasis and how far you should go in evaluating possible causes of bronchiectasis. Stefano is a man who probably needs no introduction, at least in the scientific community. Everybody is familiar with his work. He's one of the leading heads in bronchiectasis, and his scientific work in bronchiectasis has always been dedicated to patient-centered care. So Stefano, it's a pleasure to hear you again. Hi there.
Hi, Felix. Thank you so much for these nice words. Hi, Alan. Hi, everyone. It's my pleasure to be here with you this afternoon and share some idea about the idea and some research about the etiology of bronchiectasis. The agenda I had in mind is mainly based on 7 different questions that you as a patient, but also us as healthcare providers share in our daily clinical practice. The first one is, why is the etiology of bronchiectasis important? And the second one is, what are the most common etiologies of bronchiectasis? Which tests can I have to identify the etiology of bronchiectasis? Today is a special day, as we already said during the morning. So I would like also to have a couple of slides why it's important to rule out genetic diseases as etiologies of bronchiectasis, and then how far should we go in evaluating possible causes of bronchiectasis. And the final 2 questions I'll try to give an answer to is who can help me in identifying the etiology of my bronchiectasis, and how can I help my doctor in identifying the etiology of my bronchiectasis. So why is the etiology of bronchiectasis important? Over the past few hours, we discussed about radiology of bronchiectasis and the heterogeneity also of signs and symptoms. We talk about chronic cough, we talk about exacerbations and hemoptysis. There is also an heterogeneity in terms of pulmonary function. I have patients with a completely normal lung function, while some others might have an obstructive or a restrictive pattern at their spirometry. And also, you know that patients with bronchiectasis might also have a different bugs in their lungs. Pseudomonas aeruginosa, but also Haemophilus influenzae or any other bacteria, or even fungi or non-tuberculous mycobacteria. So the reason why we are facing a very heterogeneous disease is also because the etiology of bronchiectasis is different. There are plenty of etiologies. Genetic diseases might cause bronchiectasis. Post-infective episodes like pneumonias might cause bronchiectasis. We also recognize bronchiectasis associated with other diseases like autoimmune diseases, or even asthma, COPD, or bronchiectasis due to specific pathogens like non-tuberculous mycobacteria. And we also recognize as a healthcare providers, but also patients, that the first research priorities that have been identified a few years ago in this very nice project that we run with the ELF is what are the causes of bronchiectasis and what are the baseline investigation to evaluate etiology in patients with bronchiectasis. So this is the first research priorities. And if you take a look at the bronchiectasis patient passport, so as a patient with bronchiectasis, you should expect at least 12 different points we recently identified. And the second point is my doctor or nurse has performed tests to find out why I develop bronchiectasis. I've been told the cause of my bronchiectasis, or that no cause has been found despite testing. So this second point is really, really important. The sentence include different important aspects. The patient-doctor-nurse relationship, which is crucial, and I will talk a little bit about that. The fact that we need to communicate and to look for the etiology of bronchiectasis. There are some testing I'm supposed to get as a patient with bronchiectasis, and the fact that up to 40 or 50% of patients with bronchiectasis might have the so-called idiopathic bronchiectasis, why we cannot identify a specific etiology. However, identify the etiology of bronchiectasis is important first to give an answer to a patient. Second, because some of these etiologies can be treated and can change signs and symptoms, and also can change the outcomes of our patients. Because bronchiectasis might be a localized disease in the lung, but also might be the expression of a systemic disease, or even a genetic or a rare disease. Because some of the etiology of bronchiectasis might have some screening or reproductive kind of issues. And because some etiologies allow patients to get access to specific programs in the hospital or even to specific drugs. The key point is that investigating the etiology of bronchiectasis should be an individualized approach. And this is what guidelines are telling us. There are some tests that should be prescribed to all the patients with bronchiectasis, and some other tests that needs to be prescribed according to specific clinical, radiological, or other characteristic the patient has. It's not easy to design the right workup to identify the etiology of bronchiectasis. And we should also acknowledge that data and research in this field are scarce. The European Respiratory Society guidelines published in 2017 identified a conditional recommendation according to a minimum bundle of etiological tests, because it was based on very low quality of evidence. So we need to work a little bit more in this field. What are the most common etiology of bronchiectasis? I will share with you two slides. The first one is about patients in Europe. These are the data from the European Registry of Bronchiectasis. It seems a very confusing slides, but it helped me to share with you different concepts. So here at the bottom, you have the different countries, Israel, Italy, Poland, England, Scotland. Nice to see England and Scotland separated, by the way. Moldova, Finland, Malta, and Germany, and so on. And then you have different colors, and you have a percentage here from 0 to 10. So, for example, the red color is the idiopathic bronchiectasis. So these are the number of patients with no cause identified of their bronchiectasis. And there are some places like Israel where we have more than 50% of patients with idiopathic bronchiectasis, and some other countries like, for example, Belgium, with 30%. The black color is the post-infective etiology of bronchiectasis. So bronchiectasis after a specific episode of low respiratory tract infection. You can see that there are some countries like Poland with 15, less than 20% of patients, and some other countries like Macedonia with the majority of patients having post-infective bronchiectasis. And then we have yellow, for example, which is post-tuberculosis kind of bronchiectasis. We also have a color which is gray. These are bronchiectasis due to primary or secondary immunodeficiency. So there are plenty of different etiology. First concept. Second concept, there is an heterogeneity of etiology of bronchiectasis across European countries. And the third concept is that in the majority of the patient might have idiopathic bronchiectasis. This heterogeneity is true not only in Europe, but if you take a look at different research that have been run in the United States, in Australia, India, and some other part of the world. You can see that there are patients with different etiology of bronchiectasis worldwide. So these are pies from different projects, from different research. The color are color of different etiologies. And you see that there are different colors in different pies across the world. This means that there are plenty of causes of bronchiectasis, and where you are practicing is important as a sort of risk factor on that can guide you about your workup during the identification of the etiology of bronchiectasis. There are different tests that we have in our hands in order to identify the etiology of bronchiectasis. These kind of tests are prescribed by the majority of you, I think, and but not all of them, because the kind of test, as I mentioned at the beginning, is based on an individualized approach. Is based also on where are you taking care, the ability of using specific tests like genetics test, for example, or like microscopy-based kind of test. So the available resources and the multidisciplinary team are very important in order to better investigate the etiology. So if, for example, some basic data like the evaluation of the white blood cell, the evaluation of immunoglobulins, or the screening for aspergillus are suggested for the majority of patients with bronchiectasis, then we might also think to some tests like culturing the sputum in order to identify mycobacteria as an etiology of bronchiectasis. We might think to explore some genetic diseases like cystic fibrosis, or even primary ciliary dyskinesia, so genetic disease affecting the ciliary function. And we are doing this through different tests. We might want to explore a possible relationship between bronchiectasis and autoimmune disease. So this is the reason why we might prescribe some autoantibodies. We might want to look at the cilia. We might want to look a little bit more in details about your immune system, running some HIV test or some IgG subclasses or whatever. The point is that they're looking at real life. We found in Italy, but also in comparison to Belgium, for example, or UK, that not the majority of the patients with bronchiectasis undergo the right test to identify the etiology of bronchiectasis. So if you look at this slide and the number 2, which is the testing that should be performed to identify the etiology of bronchiectasis, you see that more than 60% in the UK, 60% of patients in the UK undergo the correct test to identify the etiology of bronchiectasis. In Belgium, a little bit less, 58%. And if you take a look at, for example, in Italy, there are a little bit more than 20%. So this means that there is a lot of to do. We need to do a lot, not only among experts in bronchiectasis, but also pulmonologists and physicians in general, because we want the majority of our patients with bronchiectasis undergoing the correct test. This is the slide about genetic diseases, mainly focused on cystic fibrosis, primary ciliary dyskinesia, and alpha-1 antitrypsin deficiency. So why it's important to rule out genetic diseases as an etiology of bronchiectasis? Because of several reasons. First of all, because there might be some clinical issues. These are multi-system disorders. So we need to look not only at the lung, but also the nose and several other organs. Because some of these diseases should be managed in specific setting, and because there might be new therapies available for these genetic diseases. There might be also social issues. There are some free care in some countries. There is a special legislation for these genetic diseases, and there are proper health insurance issues. And last but not least, some emotional issues related to a chronic life-limiting disease. There might be an increased risk of affected children, so family screening and procreation, and referral, for example, for genetic counseling. So these are just few reasons why, in my opinion, it's important in an individualized approach to also look at genetic diseases. The title of my presentation was How Far Should We Go in Evaluating Possible Causes of Bronchiectasis? There's no real answer based on data, because there are no very good data that are investigating this question. But a few years ago, we evaluate an extended bundle of tests in identifying the bronchiectasis etiology in 142 patients in Milan. And we found that when an extended bundle of tests is performed versus the specific individualized approach at that time suggested by the BTS 2019 guidelines, we were able to decrease the number of idiopathic bronchiectasis. So the red line is the percentage of patients with idiopathic bronchiectasis after the extended bundle, and the black line is the percentage of patients with idiopathic bronchiectasis according to the BTS bundle. And the reason why we were able to decrease the number of idiopathic bronchiectasis was because we increased the number of diagnoses of primary ciliary dyskinesia, primary immunodeficiency, bronchiectasis related to cystic fibrosis. So in order to do this, and to do an extended bundle of bronchiectasis, we might want to cooperate with different physicians and different doctors. So we want a radiologist that can help us in guiding the workup for the etiology of, find out the etiology of bronchiectasis. Immunologist is important due to the prevalence of primary and secondary immunodeficiency. ENT doctors is important because of several reasons, including primary ciliary dyskinesia. Genetic doctors or the lab in general is crucial, not only for rare disease, but also for primary and secondary immunodeficiency and several other etiologies. Finally, my last slide is about how can I, as a patient, help my doctor in identifying the etiology of bronchiectasis. So these are some steps that you as a patient might want to consider before attending the clinic with your bronchiectasis expert. First, try to remember when exactly my symptoms started, because the symptom onset and the type of symptoms are very important for us as a physician to narrow the range of bronchiectasis etiology. Second, try to retrieve, if possible, information about your birth period. I think this is really difficult, but for young people, this might be a possibility, because in some cases, the key of bronchiectasis diagnosis and etiology is in the first hours and in the first days after birth. Then third, we might want to ask our family members if anyone has or had bronchiectasis. This is really helpful, especially for genetic disorders. Think about episodes of pneumonia, including tuberculosis, you might have had in the past. Retrieve the charts, retrieve the chest radiograph. This is very important in the definition of post-infective bronchiectasis. Try to think about the occurrence and frequency of other episodes of infection in other organs, like otitis or gastroenteritis you might have had in the past. And finally, think about the presence of autoimmune disease like rheumatoid arthritis in your family. So there are some very important questions that we want you to think about before your appointment in the clinics. So finally, I think I tried to to give you an overview about the importance of etiology of bronchiectasis. I'm really happy to take any of the questions you might have. And let me thank ELF, EMBARC, and all the international friends we have been working over the past almost 10 years, I think, across Europe and worldwide in the field of bronchiectasis. And thank you for your attention.
Thank you, Stefano, for providing this comprehensive overview, which perfectly explained why it is not that easy when we talk about bronchiectasis as a whole. So I hand over to my co-chair, I guess. Or should we address the questions at the end of the session? Probably we have a question and answer session at the end. I'm sorry. So it's a pleasure to introduce the next speaker, who probably needs no introduction as well. So I congratulate the ELF that they have got the two most desired speakers in the field, Stefano and James Chalmers from Dundee University in Scotland in the UK, to have the session. James is one of the most renowned researchers and conducts and leads a lot of clinical trials, and now he's talking about putting out the fire and can we treat inflammation and bronchiectasis. So James, it's really a pleasure. James is head of the bronchiectasis registry with together with Stefano and Eva Polverino. And anything else I forgot about? I guess not. I'm happy to hear from you. Thank you, James.
Thank you very much, Felix. Thank you, Felix and Alan, and also thank you to the ELF and to all of you for participating in this meeting. What a great meeting this has been. It's been really, really enjoyable. My job for the next 20 minutes is I hope to really inspire you about the future of bronchiectasis and get you excited about where we're going with bronchiectasis research, because I think we are on the cusp of making some really important breakthroughs that can help you as patients. Before we start, I'm going to be talking in this presentation about different research studies, and so it's important to understand that much of what I'm going to talk about is research, so it's things for the future. So as I've said at the bottom here, I'll discuss medications that are not yet approved or available for use in bronchiectasis. And so important that you don't take away treatment recommendations from what I'm going to say. What I want to get you thinking about is the future. And in particular, I want to get you thinking about this concept of inflammation. And I'm going to start with a poll because I want to see also what you think about some of these things that I'm going to talk about. And my first question is, for you as a patient, how do you evaluate how bad your own bronchiectasis is? I've given a number of options here. The amount that you're coughing up, the number of chest infections, how bad you look on a CT scan or an X-ray, lung function tests, results of sputum, something else, or none of the above. I can't wait to see the results of this because I can't predict what it's going to come out as. So we've had a lot of questions in the chat today, and quite a number of them have been about this. So how do I know whether I'm doing well? How do I know if I'm struggling? And so it'll be really interesting to see what people think here. What's the single most important test? Okay, waiting for some results. How are we doing?
They're still coming in, James. Give us 30 seconds.
No problem. Good news is I was allowed to vote on that one. I've been unable to vote on some of the other ones. Here we go. It's not an easy question, I guess, because lots and lots of people will have different experience of bronchiectasis, but that's really helpful. So symptoms come out as a really important one. Number of chest infections comes out as very important. Some people also talking about the CT scan and all of the answers really getting some support. As you can probably gather, the answer to that question is going to be it's a combination of all of those things, and there's no one test that tells you how bad your bronchiectasis is or your risk of future complications. But to illustrate what we're talking about with this concept of inflammation, I want to really take you through the history of where we've come with the management of bronchiectasis. If we look back over the last 60 or 70 years with the management of bronchiectasis, if you go back to the 1940s, nearly all patients with bronchiectasis severe enough to require treatment would have been offered surgery because it was the only treatment available at that time. Through the 1950s and 60s, with the invention of antibiotics, we had the first clinical trials of bronchiectasis, which were trials of tetracycline antibiotics, and proved that those seemed to reduce the risk of chest infections and improve symptoms. Through the 70s and 80s, we had this wonderful concept that you've heard today of the vicious cycle around mucociliary function, airway damage, and infection. But then in the late 1980s, with the discovery of the CF gene, there was an explosion in research into cystic fibrosis, and many of you will know that bronchiectasis started to be thought about alongside cystic fibrosis, and much of the treatment for bronchiectasis was extrapolated from cystic fibrosis. That had many benefits for patients, but also has led to some difficulties because not everything that works for cystic fibrosis also works for bronchiectasis. And so I think the last 20 years have seen huge progress with the arrival of specific guidelines for bronchiectasis. But because of that influence from cystic fibrosis, we've been very focused on antibiotics and the concept of infections. What's really changing, I think, now in the 2020s is that we're thinking infections are very important, mucociliary clearance is very important, but also that third part of the vicious cycle, which is inflammation, is also important. And that adding that concept, I think, is going to make a big difference to how we treat patients. And I'll illustrate that with a couple of cases. So this is the case of Joan and Jill. So I've got two lung scans here. The one on the right and the one on the left are from different patients. And if I were to ask you which of these patients has the more severe bronchiectasis, now you're not specialists, but hopefully you can see that the extent of lung damage is much more severe on the left-hand side. So these are what we call cysts, much more severe radiological or X-ray bronchiectasis compared to the right-hand side. So if I took a vote, most of the doctors would guess that Jill is going to be more sick than Joan. But if I then speak to these patients and ask them how they're doing, Joan, who has the milder looking X-ray, has a terrible cough and sputum production, produces loads of phlegm, has 6 chest infections in a year, and is getting progressively worse over time. Whereas Joan, although she has an X-ray that looks quite nasty, almost never coughs, doesn't produce sputum, hasn't had any chest infection in the last year, does loads of exercise, and has an excellent quality of life. So how do we explain that? How do we explain the difference between these two people when you would be convinced the person on the right would have more severe disease and would have worse symptoms? And the answer is about how their bodies work. It's about this concept of inflammation. So when you breathe in anything as a patient with bronchiectasis or as a person that doesn't have bronchiectasis, you have a first line of defense, which are these little hairs that are being projected here that flick mucus and anything that's trapped in that mucus out of the lung. And the cartoon illustrates that clearance mechanism really well. If that's not working, which is the case in a lot of people with bronchiectasis, you need a backup plan. And the backup plan is what we call inflammation or the inflammatory process. And what's been a major breakthrough in the last 10 years has been more understanding of how that inflammatory process goes wrong in people with bronchiectasis. If your inflammation process is working properly, you have these little cells in the lungs called neutrophils, and I'll show you a little video of one of them acting just now. And they gobble up anything that gets past your cilia. They gobble up anything that gets into the lungs, using this mechanism that's being illustrated here. They're amazing cells. They follow anything that isn't meant to be there, and they try and gobble it up. You can see they move beautifully towards it, and you'll see in a moment it gobbling it up. And so alongside those cilia not working, this process of gobbling that you can see illustrated there doesn't work as effectively in bronchiectasis. And that's now been demonstrated in research studies. What happens instead is that the the cells still need to stop infections or air pollutants or whatever's got into the lung from spreading or causing any damage. And so they try to trap it. And I've got a video here of that process. Now, these are now, we've zoomed out and you can see these little cells now stained in blue. And they use sticky stuff, DNA, which is stained in red, to trap anything that they don't want to spread within the lung. And you'll see now the process as these little blue cells spit out sticky red DNA in order to trap the mucus, trap the bacteria or pollutants in the mucus. So that we now know from research studies that that's what's going on in the lungs. And patients now can understand why they're coughing up sticky mucus, because whereas in the normal airway, you have just a little bit of liquid on the surface that's there to keep things moist and keep those cilia flicking the trapped cells away. This inflammation that happens in people with bronchiectasis causes more of this sticky stuff to accumulate. It's mucus and DNA, and that's what patients cough up. But also that inflammation process over time tells the body that it needs more of this mucus. And so you make more mucus glands, which means that you have more and more mucus coming out. And that results in this stuff that we recognize that many patients cough up. So that's what happens in the inflamed airway. And understanding that is the first step to knowing what we can do about it. Now, how do I know, as if I'm a patient, how do I know if I've got a lot of inflammation in the lungs? What I've just told you gives you a clue. When I've got more mucus or when the mucus is more sticky, that means that there's more inflammation going on. More than that, the color of the mucus, you may have wondered, why does your doctor always ask you what color your mucus is? The color of mucus is like a natural infection or inflammation detection system. The green color that we see in mucus doesn't come from the presence of bugs. It's not the bugs making the color. It's actually those cells that I showed you the video of that they are actually green. They contain a protein that's green. And so when lots of those come together, they give the mucus this green color. So you literally can say when mucus is white, there's less inflammation than when mucus is yellow or when mucus is green. So what you're coughing up tells you the degree to which your lungs are inflamed. And knowing that is really useful for monitoring your own health and what's going on in your own lungs. But the question you really want to know the answer to is, if I've got inflammation in the lungs, what can I do about it? And again, research is really helping us to understand that. The first thing to say is Arietta's talk earlier today is absolutely crucial, because what's happening when you get lots of inflammation is these cells are accumulating on the surface of the lung, of the airway. This is the airway tube, and that green stuff is accumulating. If you cough all of that up by doing good physiotherapy, you're clearing the inflammation out. And so those glands will make less mucus, and gradually the inflammation will settle itself. And many people can manage inflammation just by doing really good chest physiotherapy. It's back to this cartoon of clearing the bugs out, making up for the fact that the natural defenses don't work so well by doing those really useful exercises. And there's some really great videos online of this. Is one, I think, from Southampton, of the active cycle of breathing technique, which anyone can do and which is really, really useful to clear the inflammation out of the lungs. So you're not just clearing mechanical mucus when you do physiotherapy or when you go and do physical exercise, you're also reducing inflammation. For people that have ongoing inflammation despite doing good airway clearance, we now have new research that really helps us understand what to do next. So if you're having lots and lots of chest infections, Joshua Altenberg mentioned this in her talk, there's medication like macrolides, like azithromycin. They're antibiotics, but what many people don't realize is that their main effect is actually anti-inflammatory, because they work in people who don't have positive sputum tests for bugs. So they're not killing bugs. They work in people that don't have infection because they target inflammation rather than specifically targeting the bugs. And they've been shown to reduce chest infections by about 50% and even reduce symptoms. So about 2/3 of people in the trials from this research felt better when they took the medicine. And that's because how you feel and your risk of having a chest infection is to do with having too much inflammation in the lungs. And knowing that is really, really useful. They're, of course, not suitable for everyone. There are side effects, concerns about antibiotic resistance, just as Dr. Altenberg said earlier. So we have treatments that can help with inflammation, particularly exercise and physiotherapy, but we need to think about how can we do better for you as patients? Can we design better treatments? So I've now got a question. If you had a dream treatment for bronchiectasis, but it can only do one thing, which of these would you want it to do? And again, I'll find the results of this incredibly interesting and helpful. And knowing what's gone before, I know it'll take a minute or two for the results to come through. So we're at a critical point really for bronchiectasis, where we've come through that period where macrolides, antibiotics have been the mainstay of therapy. By starting to think about this concept of inflammation, we can answer some of those questions that are coming through in the chat, like, why do my sputum tests always come back negative, but I feel like I've got an infection? Well, one of the possible explanations for that is that what you perceive as an infection is actually more inflammation in the lungs rather than being caused by a bug. And the natural logical extension of that is that the solution is not always to take more antibiotics. Sometimes the solution will be to do more airway clearance, to take more exercise, or it may be potentially in the future anti-inflammatory medication. And that's a really important way to think about, because we are very focused, I think, on the idea that it's always bacteria that are causing the problem. And I think this is fantastic. So thank you so much, everyone, for doing the poll. This really helps me as a researcher. The vast majority here are saying they want something that's going to prevent the lungs from getting worse over time. The next most popular answer is reducing chest infections. And those two things are obviously linked, because people that have more chest infections are also more likely to get worse over time. Thank you so much for answering that. So we want medicines that can potentially do both of those things. And because getting worse over time and having chest infections are both linked to inflammation, if we could find something that reduces inflammation, we could potentially hit both of those targets. But where's the big problem? The big problem is what we're seeing coming through in the chat is that people say medicines work for someone, but they don't work for somebody else. Why does this medicine work for my friend? It doesn't work for me. And it's because everybody with bronchiectasis is different. And again, we're closer to understanding that because of research. I'm going to show you some hard science now. This is a graph of patients have given sputum tests, different patients, 40 different patients, and using a very advanced technology that looks at all the proteins in the sample. Each patient is positioned on this map, like a country on a map. And you can see that every dot is in a different position because every dot is different. The inflammation in the lungs of every patient is different. And I'll label here Joan and Jill. Remember, Joan had milder looking chest CT, but was doing worse. Jill had a really nasty looking scan, but was doing really well. And on this plot, they're both completely different in terms of the type of inflammation that they have. So why would we give the same treatment to two people who are completely different? And that's a really important concept for bronchiectasis, is that everybody who's attending this meeting today is different, and we have to tailor the treatment to you as an individual. It's almost now getting to the stage we can look at patients and look at their profiles like a fingerprint. Everybody is unique. Everybody's characteristics are unique. And Stefano was going into that in great detail as well, around just how much we need to build up the picture of you as a patient. And so not everybody's going to respond to medication in the same way. And I want to see if I can illustrate that with this question. So when you get a flare-up of bronchiectasis, which many of you will do, which medicine do you find the most helpful to settle it down? Is it antibiotics? Is it steroids? Do you need to get antibiotics and steroids together? Do you usually manage it just by upping your chest clearance? Something else, or none of the above? This is a question I ask every patient that comes to my clinic, because I find it really useful as an indirect way of thinking about what type of inflammation people have in their lungs. I can't wait to see the results of the question. There we go. So about 50% say antibiotics, only 4% say steroids, but about a quarter say they also feel they need the steroids with the antibiotics. So that is absolutely textbook perfect. And I'll show you why in a moment. It's because not everybody has the same kind of inflammation. There's two main types of inflammation in bronchiectasis. The most common by far is neutrophils, which are also associated with the presence of bacteria. And that will typically respond to an antibiotic. But about 20%, which is why I said it's almost textbook perfect, also have a degree of another type of inflammation, which is eosinophilic inflammation, more like asthma, often associated with allergies. And this answers the question of why do I always have negative sputum tests, but I feel like I've got inflammation. That's very common with this type of inflammation. And recent research, so now getting into the real hard research behind all of this, shows that people that have that type of inflammation, which can be detected on a blood test or a sputum test, in this study by Stefano, nearly 50% of people had an improvement in their symptoms and quality of life when they took a steroid inhaler, which is not recommended for the 80% with bronchiectasis, but seemed to work for the 20% that had this type of inflammation. And in this study on the right, which was an injection of a medication that blocks eosinophils, that type of inflammation, from our chair's group, Felix, there was an improvement in symptoms and a reduction in exacerbations with these anti-inflammatory injections. So both steroid inhalers and these anti-inflammatory injections are now in clinical trials, clinical development for bronchiectasis, which is really important and exciting. But I told you that 80% of people have the neutrophil type of inflammation. Macrolide antibiotics like azithromycin can help with that. Antibiotics can help with that. But there were a lot of questions in the chat saying, can't we do something other than antibiotics? And so one of the main exciting things that happened last year was the publication of the first new type of drug for bronchiectasis that there's been for many years. And this is a drug that directly blocks inflammation in these cells. It's called brensocatib, or INS-1007. And it's a small molecule, magnified here for effect, that blocks the inflammatory pathway in this cell to dampen down the inflammation. Pardon me, to dampen down the inflammation in the lungs and try and essentially put the fire out. And it did that in this trial very effectively. So patients in the trial were asked to give sputum tests. The amount of inflammation in the lungs using this test called neutrophil elastase was measured, and it drops dramatically with the drug at both of the doses that were tested compared to people that got a placebo, a fake medicine. But that's really nice. We want to show lack of inflammation, but we also want to see that it benefits patients. And what we saw in the study was that patients were more likely to have infections, chest infections, exacerbations, if they got the placebo, about 50%, than if they got the medication. So the medication stopped people from having chest infections, which we hope over time would also be associated with less symptoms and less progression of the disease. Really exciting, but it's at an early stage. It's not a medicine that you can take at the moment from your doctor, but there's larger studies now going on. And it's really exciting, the idea that we could switch off inflammation without having to use an antibiotic. So I hope that over the last 25 minutes, I've got you to think about this idea of inflammation. If your lungs are inflamed, you can spot that by the thickness of the sputum, the color of the sputum, how you're feeling. Increasing physiotherapy, doing more exercise, and potentially taking other medication is the way to manage inflammation. And if we think about inflammation, it gets us away with this idea that the solution is always antibiotics, because it's not always antibiotics. Treatment shouldn't just be about living with the symptoms, but also trying to control the inflammation. So you achieve what the majority said is their objective here, which is to prevent long-term complications. What I hope I've done is shown you how exciting things are. I've shown you that we're doing trials of anti-inflammatory medications for all different types of inflammation, and also trying to tailor the treatments to individual people so that we're treating people and not populations. It's personalized medicine. I do believe that new treatments, or better treatments, are just around the corner, and the future is really bright for people with bronchiectasis. So thank you all for listening, and particularly thank you, since I'm talking about research, for all of you that have taken part in research over the years that has helped us get to this point where I think that things are really getting better. Thank you. I just want to finish by thanking everyone that's taken part here, but also I showed a number of studies there from people in our research group in Scotland, and I've shown the pictures of them here. Fantastic group of people who've done a lot of important work on bronchiectasis, so thanks to them as well.
Thank you, James, for providing this fantastic talk about research. I guess there are tons of questions, and now it's the time to hand over to my co-chair, Alan Timothy, whom I know from guideline development a couple of years ago. So,
hi, thank you, James, Stefano. Very interesting. And just for I'm a patient with bronchiectasis in the UK. In my 60s. So, but on with the important bit with the questions. I know a number of the drugs so far have come from other disease areas, such as cystic fibrosis, and particularly since Stefano raised hereditary areas, are there any gene therapies coming across or any other treatments coming across from other disease areas?
Yeah, I will take this. So, Alan, yes. There is some trial that are ongoing or ready to be designed, trying to expand some drug we have in other diseases, in other genetic diseases like cystic fibrosis, in the world of non-cystic fibrosis bronchiectasis, for example, because there are some data that are showing that there might be a role of a specific gene mutation in the world of the cystic fibrosis kind of related bronchiectasis that could be tested in this disease, and these are very brand new studies, so we need to wait some years to have the results. And I think that they might be promising, but so far I cannot tell you something more because they're ongoing.
So there's a lot of bronchiectasis patients here today. What's the next thing we're going to see as a patient that's going to make a difference to us?
Go ahead.
No, you go ahead.
Yeah. I was happy for you to go ahead because that's a really hard question, and I was hoping to hear what you were going to say. It's really hard to predict, Alan, because for every 10 drugs that are tried in clinical trials, 8 or 9 will fail to come through to patients because they're not proven to work or to be safe. And so I hope that some of the medicines that I've talked about there will come through. I've got great optimism because they've done really well in early phase trials, but there's no guarantees. So I think what we're hopefully going to see in the next few years, because there's ongoing trials, are several different types of new anti-inflammatories, which are completely new, not from other diseases. Potentially antibiotics through a nebulizer that are proven to work rather than what we've been doing, which is taking things from cystic fibrosis and hoping they work. But also you mentioned about gene therapy. Something I'm really excited about is that what's transformed cystic fibrosis are these CFTR modulators, which hydrate the mucus. Many people with bronchiectasis have problems with that same system of hydrating the mucus. And there's also now trials starting of drugs that target that as well in bronchiectasis. So it could be any of those that comes through and makes the difference. What I'm hoping to get across is just how exciting it is that we now do have 10 or 15 things that have a chance, whereas 10 years ago we had 1 or 2, which meant very little chance of it coming through.
And if I can add something more, Alan, there are some drugs that we are using in different diseases, like severe asthma, for example, that we are now testing for patients with bronchiectasis and asthma, or with the eosinophilic kind of inflammation Professor Chalmers was telling us before. And Dr. Ringshausen group in Hanover published a few months ago a case series of patients treated with a biological drug like this one we use in severe asthma and in bronchiectasis with very nice results in terms of quality of life, exacerbations. So I think that this is another area that will be touched in the next future.
So given your talk, Stefano, and I know I was involved in writing the guidelines not that long ago, it seems like they're out of date, given the advances that we now know. So when will the next guidelines will be published? Because I've been involved in a study with a well-known Italian drug company on tracking the patient's voice. James knows about it. And the poor diagnosis records and the time it takes is one of the biggest issues the study pulled out.
Yes, Alan. I think that we might have in the next future some good data about the etiology of bronchiectasis that can help patients and bronchiectasis expert in better define some guidelines recommendations in the field of the etiological diagnosis. I think this is a very, very important field. But one thing I didn't mention in my presentation is that if you take a look at the guidelines published by different society, like the Portuguese Society, the Spanish Society, the British Society, the European Society, you might see a little bit different suggestion in terms of a recommendation for the workup for the etiology. And most of these are based on expert opinion. So we really need some nice data to better evaluate the cost-benefit ratio of suggesting or ordering a specific test to a bronchiectasis patient for the etiology. About the time of the next ERS guidelines, I leave the question to Professor Chalmers.
I agree with you, Alan. It takes about 2 years to create a guideline. Our last ones were 2017. If we started today, it would be 2023, which is a long time between them. So I think we need to get started. Stay by your phone, Alan. The call will be coming soon.
So I've had some questions from patients around the hereditary, where they're saying my father and my brother and my sister. And so is it a major link, or is it something that goes to a generation, or is it just another one of the subsets that you've highlighted of bronchiectasis, Stefano?
So, Alan, we are in the field of, as I mentioned, of genetic disorders with a lung expression of bronchiectasis. So I would give you a practical approach. The practical approach is that we now have some tests to evaluate specific genetic diseases, like cystic fibrosis, like the so-called CFTR-related bronchiectasis, as Professor Chalmers was saying, alpha-1 antitrypsin deficiency. So for this kind of genetic disease, we have some tests and we have some workup in mind to make the diagnosis. However, a lot of patients, and I don't know if Felix and James share this opinion with me, a lot of patients in my clinic that have a clear genetic based or familiar based bronchiectasis, we are not able to find any kind of genetic association. And this is just because we are not there yet. We did not study in detail all the genetic mutations of the different aspects of our body that might have a bronchiectasis as a disease. So this is a huge field for research. because, as I mentioned, there are several issues related to genetic disorders, not only clinical, but also familiar, social, affective issues. But I think that both Dr. Ringshausen and Professor Chalmers can share their opinion, because they are both really into this kind of research.
So I've got a number of patients asking how they can help, and if there's any patients-funded studies. And so, what advice would you give to the patients to help them help themselves through the new research and the new investigations?
So I think I'll take that one, and the others can jump in. But I think speak to your doctor the next time you're speaking to your doctor and say, are there any clinical trials or clinical research going on that I could get involved in? Because the quickest way to access a lot of these treatments that are coming through is by taking part in a clinical trial. It's a great experience. People usually really enjoy the interaction with the teams. And I'll tell you another amazing fact, which is people that take part in clinical trials live longer. Did you know that? Probably not because of the treatments that they get, but probably because they see doctors and nurses more often, so other things get picked up. So that's another good reason to take part in research studies. You get better treatment.
Yeah, maybe I can add on your previous question. I mean, the one who asks the question needs to live with the answer, and unfortunately, the answer is not yes or no. It's a complex answer that needs to have very close look. I just want to add that with regard to your previous question.